Hey everyone, really privileged to have Dr. Richard Soden here. He's a friend, supporter of optometrystudents.com, but also a very influential person in the world of coding and billing and optometry, very well respected, and of course a very influential person here at SUNY Optometry College. We're here for you guys. We're trying to deliver you something that's really not out there, something that's hard to find, bring you something that usually comes in learning on the job and bring it to you in video format. So we're really excited for that. We hope everyone likes it, and check out the video.
Coding and billing is important because it is a significant source of income revenue for young students going into practice. So I think the first step is to talk about different coding policies, different coding arenas. The first thing is diagnoses. Patients come in with symptoms, examinations lead to diagnoses, and diagnoses lead to specific codes. So there's separate coding processes that are really important. The first is to understand that there are diagnostic codes, and that's called the International Classification of Diseases. It's currently ICD. We're in the 9th edition of it right now. Diagnostic codes do not have fees associated with them. They do not have dates of service associated with them. They just have a report of what the patient's symptom was or what the diagnosis was. There's a coding principle that specifically says that when you code a case, you code for what you find during the examination and what your ultimate diagnosis is. If there is no ultimate diagnosis, then you use a patient's symptom. The other series of codes that we have are called procedural codes, and that's currently CPT, current procedural terminology. Optometry basically uses the examination codes and some of the surgical codes within that book. We do occasionally use the codes in radiology section for procedures like ultrasound and pachymetry, but the basis of what we do are in the examination and procedural portion of that book. Procedures have dates of services associated with them, fees associated with them, and whether the procedure is a bilateral code, a unilateral code. Some procedures could be done on multiple times during the same day. Procedures can be amended with modifiers, which is a way of telling an insurance company you've done something different than the typical code. But those are the codes that we would use to report to an insurance company when we're rendering a service and asking them to reimburse us for a particular type of service. So the procedural codes are very important. What's really critical is that if you choose a code, and CPT has thousands of codes associated with it, that you meet the definition of that code. So if you look specifically at a CPT book, or if you look at some medical policies that refer directly to a CPT procedure, it's really imperative that you fulfill the obligations of that code so you can actually get paid. And if you're ever audited, you can show that you did that particular service. So if I was going to bill a visual field, let's say I was going to bill a threshold visual field, 92083 is the procedure code, it's important that the instrumentation that I have in my office allows me to do that. Optometry is in a little unique situation in that we have both what are called wellness type of examinations and medically necessary types of examinations. With that comes a whole series of different strategies for us to deal with, because some of our patients have medical insurance, which covers the diagnosis and treatment of sickness and illness. Some of our patients have vision care plans, which are particularly useful in getting care for wellness types of diagnoses. And usually they cover either eyeglasses, contact lenses at some periodic version. Those plans are usually maybe referred to as vision care plans, but predominantly I think the better terminology is that they're wellness type of examinations. Every specified time, be it a year, be it 2 years, a patient may be entitled to have a wellness examination, one pair of glasses, one pair of contact lenses, and that becomes a benefit that their employer has secured for them. Medicaid and some of the public assistance programs does pay for wellness type of visits, and I would encourage you to make sure you check with the individual plan to see what the benefit really is. So if you think in terms of a wellness visit, those are pretty much your routine vision care plans. If you think in terms of medical visits, those are your HMOs, your PPOs, your traditional types of plan, which cover the diagnosis and treatment of sickness and illness. There also are patients that have no insurance, and they can be defined as self-pay, and therefore they wind up paying for your services. But you should always be billing your services as if the person had no insurance, the same insurance, or everybody had the same plan. You should not be billing based upon an individual's particular insurance plan. One question that pops up periodically is the difference between billing for a symptom as opposed to billing for a diagnosis. ICD rules are very specific in that the ultimate diagnosis should be a real diagnosis, not necessarily a symptom, and we should be using a symptom only in the absence of a confirmed diagnosis. I think a typical good example which may help clarify the issue is a person coming in with a flash or a floater, and you do an examination which would probably involve a dilation, and you find that the person has a retinal tear, a retinal hole, or a posterior vitreous detachment. In that particular case, your primary diagnosis would be what you found: a PVD, a retinal detachment, a retinal hole, etc. Your secondary diagnosis might be floaters. In the absence of a PVD or in the absence of a retinal detachment, you can report the patient's symptom because you don't have a definitive diagnosis if you didn't find a retinal detachment or a retinal hole or a retinal tear, and in that case I would code your primary diagnosis as a vitreal floater. Most major medical insurance companies and Medicare pay for the diagnosis and treatment of sickness and illness necessitated by a patient symptom or physician-directed. Insurances, medical insurances, Medicare pays for the diagnosis and treatment necessitated by a patient symptom or physician-directed. A physician-directed visit can be patient is here for a 6-month follow-up of glaucoma, or patient is here for a 6-month follow-up of a cataract. Patient may report new symptoms, patient may report increased difficulty seeing, but there's a flow between the previous examination and the current examination. If your chief complaint is, I'm here because I want new glasses, I'm here because my contact lenses hurt, those are really not chief complaints that are medical in nature and should not be billed to a medical insurance company. So it's really important that your chief complaint is a concise statement that specifically says why the patient is here. Now, if a patient is here for a wellness examination and you find something during that examination that needs further investigation, you're more than capable and more than able to bring the patient back for a follow-up visit, and then your chief complaint would be follow-up of a cataract. Patient is a glaucoma suspect and a glaucoma evaluation is being conducted today. And I think those are really important ways, because auditors are going to look at your chief complaint, and if they don't see a chief complaint that's medical in nature, they may deny the service and they may ask for money back to the insurance company. So the chief complaint is really, really, really critical. If the patient has no chief complaint, and at the end of the visit you find no diagnosis that needs to be investigated further at a subsequent visit, then the visit really becomes a wellness type of examination. And depending upon whether or not the person has that type of insurance coverage, it can be billed to that vision care plan if they're eligible, or the visit may be a self-pay visit. When it comes to looking at examination codes, optometry and ophthalmology are a little bit unique in that we have two different sets of codes that we can use. We have the evaluation and management codes, which is a series of codes that basically 5-level codes, 5 levels for a new patient, 5 levels for an established patient, that all disciplines use for office visits. And depending upon the level of coding and the specific characteristics of the examination, you would choose a code that meets a certain level of history, a certain level of examination, and a certain level of medical decision making. And again, all professions have that. Optometry and ophthalmology are a little unique in that we have two other types we have one other series of codes called the General Ophthalmological Code. It's the 9200 series of codes, which is another coding system, another series of codes. So theoretically, when you see a patient, you can either choose a 9200 code or a 9900 code, and there are guidelines available that you need to become familiar with when to use each code. A patient is considered a new patient if they haven't been to see you or a member of your group practice if you're practicing under one tax ID number for 3 years. If they're within 3 years, then they're an established patient to the group. An office visit is using one of those codes that's most appropriate for the patient. And a good example of that be if a person comes in with a foreign body in their eye, and you do a E&M level or evaluation and management level 2, that may be what's appropriate for the chief complaint of a foreign body. Do you dilate the person? Then that may be good medical care, but certainly does that mean that you do a comprehensive or a higher level E&M level code on everybody that walks in because the symptom was foreign body? And those are things that I believe all healthcare providers struggle with. But basically, if you look at your chief complaint, you should be gearing the level of examination towards what needs to get done, thereby establishing medical necessity for that specific case. One issue that I believe all clinicians or eye care clinicians struggle with is whether to use a 9900 code or a 9200 code when you're billing a patient encounter. Let me see if I could summarize this a little bit as concise as possible. But the 9900 codes specifically have 3 major components. They have the history, they have the examination, and they have the level of medical decision making. The history has 4 different components. It has the chief complaint, it has the history of present illness, and it has the past family social medical history, and it also has the review of systems. The examination has many different components associated with it. It has 10 examination elements and 2 elements related to the mood, behavior, and neurological condition of the patient. And the level of medical decision making has to deal with the complexity of the case, the ultimate diagnosis, what types of medications are prescribed, as well as the amount of time needed to review previous data, previous records of the patient. When you look at a case, you look at specific components of each of those 3 elements and their subsequent subdivisions, and you actually check how many history of present illnesses did I record? What level of examination did I do? Did I just do an anterior segment evaluation because this was the person that just came in with a dry eye? Did I do a complete examination of all 12 elements because the chief complaint was the person was a diabetic with uncontrolled visual symptoms, or visual symptoms that were fluctuating? And then the level of medical decision making is going to be based upon what you found in the chief complaint as related to the examination. So there is a coding process that you go through, there's a checklist process that you go through, and then ultimately you come up with a diagnosis. Lots of electronic health records are doing this for us, but that has some of its own inherent problems, which we could talk about at a later point. The other series of codes that we can use for office visits are the comprehensive and intermediate general ophthalmological codes, typically referred to as the 9200 codes. The documentation for those codes are not as complicated as they are for the 9900 codes. They pretty much have a chief complaint, general medical evaluation, the need for some specific testing, and well as a series of examination elements based upon individual carrier requirements. And if you do a couple of elements, like 3 to 7, that may be an intermediate office visit. If you do all elements that relate to the chief complaint, that may be called a comprehensive examination. It's really important to know that there are some very focused definitions that have to be in place for the use of the 9200 codes. For the intermediate visit, you have to have a symptom you have to have a new symptom or an existing symptom that's complicated with a new problem. You also have to have the initiation or continuation of a treatment plan. For a comprehensive examination, you have to do specific tests such as a sensory motor examination. You also, and that could be a basic sensory motor examination, and you also have to have a gross visual field. So there are specific requirements that each of these tests have that you need to take care of. So the use of the 9900 codes versus the use of the 9200 codes is a complex subject, one that you will hear lectures on whenever you go to continuing education programs, and I would strongly suggest you get the local carrier policies in your own area. Try and review those, talk to your colleagues, and see what's going on in your community. And there are resources out there that can help you determine which is the best use of which set of codes for specific instances. In addition to the examination codes, CPT also has a series of procedural codes that optometrists need to become familiar with. These are the independent procedures such as visual fields, extended ophthalmoscopy, color vision, and some of the surgical codes that we use in our everyday practice to help patients. There are some very specific billing and coding rules as to when you can use these codes. Can you use these codes on the same day as office visit codes? Can you bill surgical codes and office visit codes on the same day? And you really need to become familiar with a lot of the independent rules. The CPT codes, the procedural codes that are in the 9200 section of the CPT book, pretty much are either unilateral codes or bilateral codes. And if you look at a Medicare fee schedule, there's an indication whether the codes are to be billed unilaterally or bilaterally. Most common procedures or most newly issued procedures are usually bilateral codes. However, if you look at procedures such as extended ophthalmoscopy, that is still a unilateral code. These codes can be billed on the same day as office visit codes. Many of these codes require interpretation and report, and a lot of audits are going on to make sure that documentation is there. Basically, for an interpretation and report, you have to make sure that you have an indication in your medical chart why the test was ordered, what the test results were, was the patient's status reliable, such as visual field, was it a reliable visual field, and then what are you ultimately going to do about it. So a good example might be if you're doing a visual field level 3, 92083 for a glaucoma suspect, you may wind up saying, I ordered a 24-2 because the person was a glaucoma suspect based upon elevated pressure. My findings included a isolated scotoma in the right eye in the superior nasal quadrant, good reliability on the test. What am I going to do about it is I'm going to repeat the test in 6 months or a year and see if there's any changes noted. And that constitutes the documentation that you would need in order to bill that procedure. That happens to be a bilateral procedure, so if you're doing it on both eyes, you only bill the code 92083. You don't need any specific modifiers. If you only do it on one eye, there's a modifier for reduced services. Some of the other major codes that we need to use occur in the 6500 series of codes, which are the surgical codes. Now, even though these appear in the surgical section of CPT, procedures such as foreign body removal, procedures such as insertion of punctal plugs have been included in the surgical section. These are pretty much unilateral procedures, so that means if you're billing them in each eye, you would have to use the guidelines that the insurance carrier has, which typically involves modifier, and become familiar with the documentation required in order to fulfill those codes. Whether you can bill a surgical code and an office visit code on the same day is really dependent upon whether the office visit was for that procedure or whether there was another symptom. So if you're going to fit somebody with punctal plugs, a good example might be if the purpose of that visit was strictly for the punctal plugs, then you would not wind up billing an office visit on that day. The office visit might either be a 99 or a 9200 code. However, if the person came in and you were going to fit him for punctal plugs, but you also found that he had a new symptom of a floater, you can include a office visit code, and you would amend the office visit code with modifier 25, clearly indicating that on that particular day the office visit was required because of the floaters and not because of the need to put the punctal plugs in. And that's another series of coding strategy that you're going to have to become familiar with in order to make sure that your records can support the documentation that you've built.